Yes, shall we proceed?
Yeah, Nakul, please proceed.
Yeah, thank you. Yeah, good evening all. I welcome all acute cluster team, which includes Pharma, Inventia, Xenix, IVA, as well as Synergy team, to this scientific Meet the Expert webinar. Hi guys, I am Nakul Patil, working as a senior product manager. We at Emcure, we are the purpose-driven organization and dedicated towards the offering effective medicine to cure patients and enable healthy living. And we at Acute Cluster having FCM franchisee with epitome of quality and success. Till Emcure has helped more than 60 lakh Indian patients to rapidly correct iron deficiency anemia. And furthermore, we are taking a pledge for making India iron strong. Today, Emcure team is honored to have esteemed speaker, Dr. Sonia Naik. Just I'm sharing her CV. Yes, Dr. Sonia Naik, she is a director and unit head at Cloud9 Hospital, Kailash Colony, Delhi. She is a executive member, endometriosis and endoscopy committee, AOGD. She is a past editor and fetal medicine society. Her area of interest in gynec endoscopy, and she is an expertise in management of endometriosis and menopausal health. She authored a book, Instant Gynecology, and she was awarded the Rotary Vocational Award for Lifetime Achievement in Maternal and Child Health, the most inspiring gynecology by Economics of Times. Yeah, once again, welcome to Dr. Sonia for giving us opportunity to host this scientific Meet the Expert webinar and be a partner for this wonderful academic educational initiative. Today, Dr. Sonia will sharing her views on real life scenario of usage of ferric carboxymaltose. And I want to highlight one thing over here to all delegates. Surely our expert will address any doubts, any questions related to FCM, related to anemia. Once session get over, definitely Dr. Sonia will address our whatever the queries are there. Once again, welcome Dr. Sonia, and over to you, Doctor.
Thank you for such a nice invitation and for the kind words. A very pleasant evening to every one of you. And I'll just share my presentation. So basically, we are going to discuss today definitely somewhat some basics of iron deficiency anemia, but my prime objective today is to discuss about the intravenous ferric carboxymaltose in the management of the iron deficiency anemia. So anemia, as we all know, it's a global burden, just not in our country, but it's a global burden. And you will all realize over here that we have a global map over here. And in our country, it's actually a level of public health significance. It's a severe, we come into the severe iron deficiency anemia status as per the global map. And the prevalence of anemia globally is 41 to 56%, whereas in our country, it is 52% still in our pregnant women, and in the non-pregnant women, it is 57%. So if we take all women together, it's around 59%. So it is 51 to 60% still prevalent in our country. And if we look at the CDC guidelines and the WHO guidelines telling us about what is the stages of the anemia. So we call anemia if the hemoglobin is less than 11 in the first trimester during pregnancy and less than 10.5 in the second trimester. And according to WHO, anything below 11 is termed as anemia during pregnancy. And if we look at the WHO's classification of severity of anemia in the adult females, whether pregnant or non-pregnant, and if we talk about the non-pregnant, mild is 11 to 11.9. So anywhere below 11, is during the pregnancy, and 11 to 11.9, even non-pregnant status, mild anemia. So that means below 12 is mild anemia, and moderate is 8 to 10.9, and severe is less than 8. And during pregnancy, it becomes 7 to 9.9, a moderate, and less than 7 as severe anemia. And postpartum, if we talk about, hemoglobin less than 10 according to WHO, according to FIGO less than 11, and according to the UK guidelines less than 10. So less than 10 to 11 postpartum, we term it as anemia. So very clear about these guidelines. So therefore, in general, less than 11 should be termed as anemia, and depending on the severity, then we manage these patients. Now, if you look at the total iron requirements in the pregnancy, if we look over here, this graph over here, during the first trimester, you can see the requirements over here, which are 0.8 milligrams per day. And now when we look at these requirements, it's rising in the second trimester, and look over here from 0.8 milligrams per day, whether it's in the first trimester or in the non-pregnant state, it rises to 7.5 milligrams per day in the third trimester. That means almost 10 times that of a non-pregnant or a first trimester. The iron requirements increase during the pregnancy. And average daily absorption from our Indian diets is 0.8 to 4.5 milligrams per day. So whatever, even if we take a normal healthy diet, still we don't suffice in our iron intake per day with our Indian diets. So the total requirement during one singleton pregnancy is 1,000 to 1,200 milligrams during the entire pregnancy. And if we talk about consequences of the iron deficiency anemia, we all know that definitely it will lead to physical discomforts like shortness of breath, fatigue, palpitation, tachycardia, and that can also lead to nausea, weight loss, abdominal pain because of the resultant hypoxemia. And central hypoxemia, as we know that mostly the women will complain that I'm having dizziness. So that, and also to the cognitive impairment. Now, during pregnancy, iron deficiency anemia not only leads to preterm delivery and preterm rupture of membranes, but it leads also to preeclampsia. Because of preeclampsia, also to intrauterine death. Intercurrent infections are more common if one is anemic. The women is hyperproteinemic also, so lots of swelling also. So antepartum hemorrhage can happen, congestive heart failure if the hemoglobin is of a severe, iron deficiency anemia is of a severe kind. And fetal complications definitely will happen because of all these maternal complications leading to fetal complications like low birth weight, prematurity, infections, congenital malformations, neonatal anemia, and abnormal cognitive development. So maternal anemia contributes to around 18% of perinatal mortality and 20% of maternal mortality in South Asian countries, including our country. So how do we diagnose this iron deficiency anemia? Definitely history and clinical examination will help us in this, but also what investigations will you order when you see this sort of a patient? CBC, definitely. So in CBC, our hemoglobin, RBC count, hematocrit, reticulocyte count. So if you look at a low MCV, low MCH, that means it's an iron deficiency anemia. Along with low MCV, low MCH, if you have an elevated RTW, then it's a sufficient evidence of iron deficiency anemia, and that means you have to start iron therapy if there is an elevated RTW. But the RD, how do you differentiate it from a thalassemia? In thalassemia also you see a low MCV, MCH, but you will see that the RDW is decreased in thalassemia. So therefore, now what about the iron studies? Should you order the entire iron studies? Does it really help in the pregnant patients? So if you look at these parameters, total iron binding capacity, serum iron, transparent saturations, they are not reliable markers in pregnancy because serum iron shows diurnal variations. And pregnancy itself increases total iron binding capacity even in the absence of iron deficiency anemia. So therefore, the most appropriate one is the serum ferritin and a cutoff of 30 micrograms per deciliter to diagnose and therefore to treat iron deficiency in pregnancy. Along with that, a peripheral blood smear, a bone marrow examination only if required, hematology. So we all know that our country has now taken up this mission and we term it as Anemia Mukt Bharat, which this mission was taken up in 2018 as a protocol for managing anemia in pregnant women. So in the first level of treatment is, if there is mild to moderate anemia, the first level is give them 2 tablets of iron and folic acid, which contains 100 milligrams of elemental iron, 500 micrograms of folic acid daily for 6 months. And parenteral iron may be considered as a first line in pregnant women who are detected to be anemic late in pregnancy or in whom compliance is likely to be low or absorption is low or she has a lot of gastritis or nausea and vomiting or constipation because of which she is not able to take iron. So in these patients, again, we'll prefer giving IV iron. So IV iron, even in the even in the earlier pregnancy, in mild to moderate anemia, in cases of if the patient is not compliant or she cannot take oral iron, and in the later pregnancy, in case we don't have time sufficient to build up with the oral iron. So if no improvement is seen after the first level of treatment, anyways, again, IV iron that you will advise her. In severe anemia, the first level of management is definitely start with the IV iron after stabilizing the vital parameters of the women. So therefore, coming to the indications of parenteral iron therapy, failure of oral iron therapy, non-compliance or intolerance to oral iron, late second or third trimester with moderate to severe anemia, rapid rectification of anemia and repletion of the iron stores, malabsorption, bleeding the abscesses when hemorrhage is likely to continue. And contraindications would be that we'll not prefer to give it in the first trimester, that is gestation age less than 12 weeks, lack of facilities for resuscitation. So you have to, that means give parenteral iron therapy only in a hospital setup where there's a facility for resuscitation in case of any allergies or anaphylactic reaction. So you will not give it in a clinic or OPD sort of or daycare area where in case these patients cannot be resuscitated in case of any anaphylaxis. So IV iron therapy therefore is superior to oral iron in terms of speed and absolute extent of rise in hemoglobin and replenishment of iron stores. How have we evolved over with the intravenous iron? So we all know we have been evolving with the parenteral iron, not only just the intravenous iron. We started in 1932 with a ferric hydroxide, ferric saccharide, then low molecular weight, the ferric gluconate, and we had ferric carboxymaltose coming in 2030, and then in 2020, maltoside also was introduced. Now, the structure of this iron is basically, there's a carbohydrate shell all around, as you can see very clearly in the picture, and oxyhydroxide core is inside. So there is a rapid release of large amounts of labile free iron leads to toxicity. We know that leads to toxicity. So currently available IV irons are actually iron carbohydrate complexes, which are based on spheroid particles, each consisting of a core of iron surrounded by a carbohydrate shell. Now, how does it help this sort of a carbohydrate shell? So larger, more complex carbohydrate shells of newer IV irons that allows controlled release of iron from the core and mitigates the release of labile free iron, which can lead to adverse drug reaction. So this allows administration of large doses of iron, complete replacement dose in a single dose in a short time duration. So we know that the properties of an ideal parenteral iron in terms of the molecular weight, the stability, the half-life. If we compare over here, the iron dextran with the iron sucrose with the ferricarboxymaltose, we would find that it is highly stable, that the half-life is short, the pH, the half-life is long, and the pH is neutral, it is isotonic, lower antigenicity, and does not require a test dose, short time for injection, short time duration of the injection, and we can give a maximal dose in the shortest possible time in a single dose. And that is fulfilled by the ferric carboxy maltose as compared to iron dextran and iron sucrose. So therefore, if we look at over here, these parenteral irons are divided into type 1 complex, type 2, and the type 3. And type 1 are the ferric carboxymaltose, iron isomaltosite, ferromoxitol, and iron dextran. And type 2 are the iron sucrose. And the type 3 is the weakest iron, intravenous iron, that's the ferric gluconate iron citrate and iron sorbitol. So the approved iron preparations have been iron dextran, ferric gluconate, iron sucrose, ferromoxitol, ferric carboxymaltose, and iron isomaltosite. Now, what are the limitations of the parenteral iron? So, iron dextran, we are all aware of it. That it used to cause serious allergic reactions. So the risk of serious adverse effects was greatest with this. Intramuscular injections were involved with iron dextran, and which were very painful, stained the buttock or stained, and therefore required multiple injections. Now, the low molecular weight of iron dextran was associated with lesser side effects, but the test dose was required and longer IV infusion time was required of approximately 1 hour. Coming to ferric gluconate, that was the only approved for treatment of iron deficiency anemia and chronic kidney disease receiving hemodialysis, and could be only administered in low doses. Multiple clinic visits therefore required. Iron sucrose, we have all very, very frequently used this because it was quite a safe iron molecule, and therefore it could be administered in low doses as associated with high labile free iron release, and multiple clinic visits were required. Ferromoxitol, only approved for treatment of IDA and CKD, maximum allowed single dose as which is lower compared to other third generation parenteral irons. And isomaltosite, it contains the highest amount of labile iron among the third generation. So more the labile iron, more the risk of hypersensitivity reaction. So the advantages, therefore, we also saw that this ferric carboxymaltose withstood all the parameters of the ideal iron. So it overcomes the low dosage limitation. It's a type 1 dextran-free robust iron with long half-life, stable complex, structural similarity to ferritin, low antigenicity, and no test dose required. So therefore, it's a robust parenteral iron not associated with dextran-induced hypersensitivity, can be administered in much higher doses, short infusion time as short as 15 minutes only. Iron is released slowly, avoiding toxicity and oxidative stress. Structure is similar to ferritin. At test dose is not required, and low antigenicity. So qualities are best suited for real life, therefore clinical usage. Now we have this FCN 750 milligrams, 3D, that's a dose, dilution, and duration. So how do we calculate the dose? Calculation of the cumulative iron dose, and calculate the total iron requirement based on the existing hemoglobin and weight of the patient. So the weight of the patient is important. If the hemoglobin is less than 10, weight is less than 35 kgs, then 500 milligrams only. If the weight is 35 to 70 kgs, then 1500 milligrams. That means you can give 750 mg twice, 70 kgs and over 2000 milligrams. So my the hemoglobin is less than 10, 70 kg and plus, you can give 1 gram shots twice at 15 days interval. And if it's 10 to 14, then 500 milligram again below 35 kg, 1000 milligram at 35 to 70 kg, and 1500 milligram 70 kg and over. So these doses can be easily accommodated with the 500 mg ampule available and with the vial available and the 750 mg available. Now, adverse reactions of FCM are considered potentially related to the long duration of infusion administration. So therefore, you have to really specify that if you are infusing 750 mg of the FCM, just infuse in 15 minutes and in 250 ml of normal saline. So this has to be reinforced, reiterated to the staff, to the nurses, in the ER, in the daycare, or wherever you infuse iron, the hospital setups, that they should not let it hang for a long time, and it should finish in 15 minutes. So dilution of FCM in high volume of saline beyond recommendation provided is not permissible. And possible mechanical long duration of administration, excess dilution may lead to destabilization of the iron complex that may cause adverse effects. So wherever the adverse effects have been noticed with the IV iron, and we have tried to ask from these places what is the possible cause, and the most common cause was because it was given over a long duration of time, or it was diluted in more amount of saline. So one has to be very, very careful with the administration. So therefore, the staff has to be trained to evaluate and also manage anaphylactic reactions in an environment where full resuscitation facilities can be assured. And the patient should be observed for the adverse effects for 30 minutes following each FCM infusion. So majority of the Indian patients with anemia have weight between 35 to 70 kgs and hemoglobin less than 10 milligrams. Therefore, the calculated iron requirement by weight and hemoglobin chart will be 1500 milligrams. Therefore, 750 milligram, 2 doses, 1 week to 2 weeks apart. And this offers flexibility to the doctors. They can choose 500 to 3 injections or 750 to 2 injections. And many patients who are non-affordable for FCM 1000 mg, FCM 750 mg would be an ideal one to provide good hemoglobin price. So the same reiterated over here, the dosage and with 35 to 70 kgs and more than 70 kgs. So now what is the clinical evidence of 750 mg in management of IDA? Now, this is an Indian study over here, and the objective was basically, the primary endpoint was changed to the highest observed hemoglobin from baseline, and the safety endpoint were the various side effects. And over here, at least 10 years of age was the inclusive criteria, where the screening hemoglobin of not more than 11 grams, with the ferritin levels of not more than 100, and transferrin saturation was not more than 30%. And the key findings were that the mean hemoglobin rise was greater in group A, FCM group. The group B was the oral iron group. So it was a significant increase that was noticed in this group. So significant mean increase in hemoglobin from baseline to highest value was seen in the group C, that is the FCM, versus group D, the standard of care. And safety endpoints were that it was safely tolerated in the group. So 2 750 mg FCM infusions are safe, therefore superior to oral iron in increasing hemoglobin levels in IDA patients. And FCM can be administered 2 infusions of 750 mg 1 week apart, which was safe and effective and considered as a treatment option for IDA in patients, in subjects who have an unsatisfactory response to oral iron, as well as those who are intolerant of the oral iron, who are not compliant with the oral iron and not suitable for the oral iron. Thank you. Any questions?
Yeah, ma'am. Few question I can see in chat box. You that described about the anemia and related the rationale of ferric carboxymaltose. That was nice. Means you mentioned that dose dilution and duration of FCM, how to dilute it and how to what would be the duration. And based on that, few questions came from our field team. That someone, Mr. Pradeep, is asking, FCM can be given from which age and what would be the minimum weight of the patient?
So as we said, even it can be given that at a weight of less than 35 kgs also, but we have to reduce the dosage to 500 mg. So I showed you in various charts that it can be given. So, so that's not a problem, the less weight patients.
Nakul sir, unmute yourself.
Sorry, this question from my side. Rightly, you mentioned that blood transfusion. Is that iron infusion better than blood transfusion?
So definitely in case of mild to moderate anemia, we would always prefer an iron infusion over a blood transfusion because blood transfusion has its own risks and side effects, which we would not prefer the patient having it. And we are all aware of the blood storage, blood donation, everything has its own limitations. It's not easy to have blood donation camps and have blood storages and all. So we always have to limit the blood transfusions to patients who actually require it in
Yes.
severe IDA or in patients in who are having a hemorrhage also. But
Absolutely.
in iron deficiency anemia, we would actually really feel better, and we would really welcome everybody if in case everybody is comfortable giving iron infusions and not promote blood transfusions at all.
Means, ma'am, as per you, that who's having more, severe anemia means more than less than
iron
6.
deficiency type, even a
Yeah.
severe iron deficiency anemia, if the patient can be actually managed by a iron infusion.
And what would be the side effect, ma'am, with blood transfusion?
So blood transfusion, I mean, the infections can happen,
Right.
the anaphylactic reactions, allergic reactions are very common. And obviously, if you tell a layman that you're getting a blood transfusion, the person will never be happy. So you don't want to give it honestly. And as I told you, I mean, the limitations, there are a lot of limitations in our country with the blood transfusions.
Yes, yes. That, ma'am, next question from Mr. Jogendra Rana. He's asking, what is the role of molecular weight in parental iron and how it will be effect on its efficacy?
See, the higher the molecular weight, one, the absorption, it affects the bioavailability, and it also affects the antigenicity. So everything gets affected because of the molecular weight. So now we are coming to everything which is nano. Absorption is better with the nano, okay, the smaller low molecular. So that is how it is.
At in presentation, you mentioned that isomaltoside means whatever the labile ion, you talk about the labile ion. That no, ma'am, in market there is a one molecule is there, that is the isomaltoside, and that isomaltoside has the more labile ion, which cause the reaction. But still, many doctors they are using. Means, is that any other reason is there?
It's just the ease of administration, nothing else. New molecules of administration, but yes, we have. I think FCM has stood the test of time.
Correct. Jogendra, any question from your side?
No, thanks, sir.
Right. Ma'am, one more question. in chat box. So how CBC reports is important to evaluate anemia, and which parameters we need to more focus on?
See, definitely, I mean, hemoglobin, whenever we see the CBC report, the first and the foremost information that we want is the hemoglobin kitna hai, theek hai? Once we know the hemoglobin, then we have to, suppose the hemoglobin is low, okay, then we next want to know what sort of an anemia it is, whether it's a B12 deficiency anemia or a folic acid deficiency anemia or some other sort of anemia, or anemia because of the worm infestation. So there's so many types of anemias. Therefore, we start looking into different parameters. We see the MCV, MCH, the PCV, and then we see the REW also, the reticulocyte count. So we see into all these parameters. Then once we see that there's a low MCV, low MCH, which is common in any microcytic hypochromic anemia.
And what about
Causes of the microcytic hypochromic anemia, like a thalassemia or a iron deficiency anemia. So now the management of thalassemia and deficiency anemia will be totally different. Okay, so then you see the RDW. Then you come to the next step, and then you see if there is decrease in the RDW, then you go in favor of thalassemia. If it is increased, it's iron deficiency. Then you do now when you have a suspicion in the CBC report that it's an iron deficiency anemia, then you go forward with the iron stores. Now in a non-pregnant state, iron stores are still quite reliable. But in a pregnant state, we will straight away want a serum ferritin than doing an iron profile.
correct, ma'am? And what about the ma'am ferritin and transferrin level? That
is what I said. I mean, then we would want a ferritin levels in pregnancy.
absolutely. In suppose if patient suffering from means that doctors diagnose patient, but that patient is means finding is unexplained anemia. So what would be the treatment?
So in unexplained anemia, we would also supplement with the folic acid and B12 other than the iron deficiency. We would also give different others. We'll deworm her and we'll see that there's no other reason for the blood loss also.
Right, ma'am. That means last question, ma'am, from Dheeraj. He's asking that one of my doctor is using 500 mg FCM in 250 ns in 30 minutes and using with the same protocol with the without any adverse effect. Is he doing the right thing?
No, I think one, you are increasing the time. One, you're giving, see, 500 mg, if it's a less than 35 kg patient, it's fine. But if it is normally in Indian population, we'll find that most of us are between 35 to 70 kg. Then 500 mg is too less. You're just wasting your time, you're wasting your patient's time. One, you're doing over a long period of time, 30 minutes. You are unnecessarily making the patient wait. Then again, you'll ask the patient to wait for 30 more minutes to observe for any adverse reactions. The second, you are giving more chance for the iron to destabilize. So you're giving that chance. Abhi tak, so you have not had any adverse reactions, but you're giving a chance for any adverse reactions to happen because it is given over 30 minutes, whereas it should be given over 15 minutes and more diluted dose. So if you have to give a patient iron, you give sufficient iron in one go rather than repeat again and again. If you're giving just 500 mg, then you probably have to give 3 times infusion rather than twice infusion with the 750 or the 1 gram.
Correct, ma'am. That very important that administration of FCM, that
Yeah.
in right dose, dilution and duration is very important. Yeah. With this, ma'am, we are concluding this Meet the Expert program. Thank you very much. Means more than 1,000 our Emcurians they have attended this webinar, and definitely means they you taught well, and definitely they are taking a good message, or that's a scientific learning they have taken from this webinar, ma'am. Yeah, thank you very much, ma'am. Thank you. Thank you.
Bye-bye.
Thank you, Jogender.
Yes, thank you. Thank you,
Yeah.
ma'am, for giving a valuable time, ma'am, and all my colleague has benefited, ma'am.
Okay.
Thanks a lot, ma'am.
Okay, bye. Bye.
Thank you.
Yeah, thank you. Yes, you can stop that recording.